Okay, so good evening, everyone. I hope everyone is well. We are here tonight for what did I call this one? The facts, the facts with Dr. Jack, the facts about PCR testing with Dr. Jack. Dr. James Lyons-Weiler is here with us, our good friend. And we, as always, are honored to have him join us tonight to talk about PCR testing. I mean, there's been so much in the news about tests. It's all about, well, it's about cases. Actually, there hasn't been enough in the news, in the mainstream news anyway, about testing. There's been a heck of a lot about cases. And so what I want to talk to you about tonight, Jack, is about uh, one of the main things I want to focus on tonight is the relationship between testing and actual cases. But before we could even get into all of that, I want to talk about testing and the problems with testing. And before I can even get into that, though, I want to talk about what is PCR testing, because a lot of people, I think, don't really understand what it is. They don't understand what this replication cycle is, amplification cycle. I don't even fully understand it myself. So I know that I've come to the right place. You're the person who can sort of break this down for us in layman's terms as much as you can. But if you could just start out and let us know what is PCR testing.
Sure. So, Brian, I want to say thank you, of course, for having me on there. On doing this is very important service to the community and to the public in general. So, you know, before we get into PCR testing and the technical details of it, what I want to say is, of course, just keep pointing to the death rate. And whatever they say the case rate is, point to the ICU rate, point to the death rate. And when I say death rate, I some people want to say the infection case fatality rate. That's fine if you have some idea of how many are infected. But we have to deal with the false positives. This onion is so layered. It doesn't mean that it's so complicated you can't understand it. But if you just focus for the next week on what the death rate is, try to find out what the death rate is, how many people, what percentage of ICU beds are filling up right now compared to what were filled up every November for the past 5 years. Focus on that. That gives you a relative perspective. I think that's a little bit better than saying, okay, we're going to go nitty gritty right down to the molecules and what's happening with the DNA and the primers or RNA and the primers and so on. So, because let's say that they say that there's 10,000 infections. If you have 10,000 bona fide infections in a population, you're going to want to know how many of those are really sick, how many are asymptomatic, how many are deathly ill, how many are seriously ill, how many are ICU, and how many died. And then we can get a better idea of what kind of whether this is serious or not, and also tracking those statistics. Those are the statistics, the death rate per infection that we should be tracking over time. And I want to point everyone to Ethical Skeptic on Twitter. If you're on Twitter, go to Ethical Skeptic. He's had a hold of this for months. Um, but lately, he's starting to see an uptick uh, in the deaths per infection as well. And I have some ideas on that. It's fairly complicated about why the death rate would appear to go up. But the simplest thing that I can say, people are dying from flu, like they do every year, but there's no flu diagnosis. So in there lies part of your answer. Okay, so going down deep into, if you're going to run a PCR in your kitchen today, which you can do. Did you know you can run PCR in a kitchen? Okay, all you need are the right reagents and you need a toaster oven. Kerry Mullis, the guy who invented PCR, came to him in an LSD induced vision where he realized that the polymerase that people were studying, the biologists were studying at the time, hey, we could do this in a bucket. And this is how he was thinking. And he actually did the first PCR reaction in a toaster oven. The first
Wow.
proof of principle was in a toaster oven. In the way that PCR works, I've taught this in classes. I have conducted PCR reactions myself many, many, many times. What you have is called target DNA. You can't do PCR and RNA. We'll get to that in a minute, but you have target DNA. If you wanted to sequence your genome or part of your genome or your MTFHR sequence, you have to isolate the DNA from the cell. So once you have an isolated genomic DNA sample, you don't want to amplify all of the genome. You just want to go in and you want to look at a targeted piece of it. So you're going to create what are called primers, 21, 18, 19 base. They're called oligonucleotides. These are strings of molecules, the bases of DNA, A, T, C, and G, that match a region that is upstream and downstream from your target. As you know, the DNA is a double-stranded molecule that is, got hydrogen bonds between it. So it's a helix. Um, so you have to be able to localize and isolate the part that you want to amplify. And we do that first with a round of excision that's not modified. It's effectively excision, but because the DNA will only bind to that part of your genome. And it should be designed. Those primers that you pick, you got to have a primer of a north and a south primer. You have to pick a pair of primers that is very specific to that region. Otherwise, you're going to have non-specific targeting. Okay, so you have the target in the middle, and you've got the primers on the end. What happens with polymerase in the reaction is polymerase comes in and it attaches to the DNA right where the primer is connected to the open end of where the primer is connected to the DNA of the target. The polymerase then extends those DNA sequences, right, closer and closer and closer to each other, like this, and it grows base by base by base by base by incorporating what are called DNTPs. These are the letters of the alphabet of DNA. Okay, there's the adenine, thymine, cytosine, guanine. You had them all in high school, the A, T, C, and G. So as it adds it base by base by base by base, it makes two copies from one. That's why it's a chain reaction. When you get the first copy made, you actually are making two copies because DNA is a double-stranded molecule. So then those two copies are available to be copied again. And then the polymerase comes in and then it duplicates those two. So two become four, four become eight, and so on. This is done through a cycling of temperatures for the most part. You have 72 degrees or so will cause the DNA to open up, right? It melts the DNA, right? And then you cool it down to 50 or something, 50 or so, 56. I use usually the temperature. That's the annealing temperature. And then you have a mid-range temperature where the polymerase will extend. So every cycle goes through a stage of temperatures. That's why Gary did it in the toaster oven, because he could manipulate the temperature. So you keep it steady for a certain amount of time in one cycle, and then you bring it down cool to anneal the DNA back together, and then you do have an extension. And you cycle this over and over and over. And so if you do it two times, every time you do it, you get a doubling. So if you do it two times, you've done it you more than quadrupled. It's an exponential reaction. So the number of cycles that we're all talking about it gets really confusing because every patient, every lab will run a cycling machine in PCR a certain number of cycles. So there's a default number of cycles that you run it out for to make sure that you get amplification is just a default number. But then you have to go back to the data and you have to say, at this magic number, this threshold of cycles, did I get enough copies? The lower the number of initial starting nucleotide material, right? Then the more doubling you're going to have to do to get to the exponential phase. So that's why it goes this way. If you have a lot already, you're going to get to the exponential phase early. If you have a little bit, you're going to get to it later, right? So using the bottom end of the screen here, this is the number of cycles, 1, 2, 3, 4, 5, 6, 7, 8, like that. And if you have a lot, when you do quantitative PCR, if you're already halfway there, you're going to hit that exponential really quickly.
And I should have asked you this earlier instead of in the middle of the interview, but it's just coming to my mind now. If you have a graphic you'd like to share at any point tonight, it doesn't have to be right now, but in a few minutes, if you have a graphic, I can, there's an icon to share your screen at the bottom. Sure. I know you've posted a lot of really great graphs of exactly what you're talking about. Well, some of what you're talking about. You've also the amplification cycles and everything on Twitter. So I don't know if people follow you, how many people follow Dr. Jack, but you can find him at, I believe it's just at James Lyons-Weiler, isn't it?
At jameslyonsweiler.com, but IPAK is ipa-knowledge.org.
But I mean on Twitter.
On Twitter, it's at Life Biomed Guru, actually.
Oh, okay. I don't know
At
what.
Life
Well,
Biomed
you can still
Guru.
search by your name though, because that's how I found you originally.
Yeah, I'm everywhere, man. People are
Yeah,
calling me
yeah.
up saying, "Get off my computer!" Everywhere I turn, I see you.
So
Um,
you've been having some. Actually, that's how this came to my attention. Is I don't follow Twitter as closely as I should. I admit, even though it's the primary means of communication these days. Well, maybe not for long, but my wife actually pointed out. She said, Dr. Jack's been posting some great stuff about PCR testing. You should really have him on for an interview to talk about it. So you can thank her for bringing this together as well. But there's just so much that, like I said at the beginning of this, so many people don't understand. Thank you for that explanation. I kind of want to understand now what the problem is, and what the biggest problem is with the data that we're receiving. I think maybe you want to talk a little bit more about PCR testing, but
I'll
the
just show this
cycles.
right here. So here's the cycle number on the x-axis. The machine is going
See if
every
I can put it
cycle.
up. There we
Yeah,
go.
every. Can you see it?
Yep, I
Okay,
have it up now. It wasn't added to the stream, but it's up there now.
so every cycle is a thermal cycle. The machine is actually called a PCR thermal cycler. So it goes through a cycle of temperatures. Those temperatures with the right enzymes and the right components in the test tube will enact a polymerase reaction that extends the DNA and makes copies of DNA. And so what you're looking at here is the cycle number. The machine cycles from 0 to 40. Okay, that's the default. But someone who did this graph, I just got it off of Google, someone who did this graph has determined that the optimal number of cycles where you should look at the data to determine the relative quantity of original starting nucleotide material is 19. That's the exponential phase of that curve, right? That's measured by fluorescence.
Mhm.
So this is what I was talking about. If you could imagine in your mind that the green line is shifted to the right, that's because you started with less material. You didn't get to at cycle 19, your value is going to be lower. Okay. So if you can imagine the green line shifted to the left, you started with more material. You're getting there just by cycle 10 or cycle 15. But if you to get to that threshold amount of detection, you have to wait till cycle 19. You may or may not have it. It depends on what the test is saying. So the longer you have to wait in time, the larger the number of cycles, the less starting material that you have. And so a definite assumption here is that the starting material that you have um, is enough to start a reaction, and that it matches the primer set. So one more detail on PCR I have to add, of course, is that we're talking about RT-PCR. People are saying, "What is RT?" Well, that's reverse transcriptase. You actually can't do PCR on RNA; it's not stable enough. So you have to do an initial reaction where you transcribe it using reverse transcriptase from DNA, from RNA to DNA. And then you have it double stranded. So RNA is not stable enough. It can form double stranded. Usually it can make all these, it can form three-dimensional structures. But RNA being single stranded, it's not going to work for you. You only have a single strand of RNA. You're not going to get that double amplification. You're going to get linear amplification. So you make it into double stranded DNA, then you can do the PCR on it. It's a valid technique for PCR for quantitative to try to see how much RNA you have in a cell. If you're expressing a bunch of genes, you have a lot of RNA from a bunch of genes, and you want to know which genes are up, which genes are down. I've done that. It's called transcriptome analysis. I can't tell you how many studies I've done like that. It's just it's a lot of fun to understand what makes a tumor a tumor, which genes are turned on, which genes are turned off. It's a really fascinating area. But in terms of viral diagnosis, then viral detection. In terms of viral detection, there's a shortfall in PCR, which is if your starting material is crappy, you're not going to get a viable reaction. So
Mm-hmm.
if your starting material it has low viremia, you might not ever get to the threshold and say, oh, wait a minute, it's really there. But you also have the problem, as many people know now, it's all over the place, that you could have dead viral fragments, remnants, non-viable viral fragments of a person that's not infectious or no longer infectious, and you can get an amplification off of that. And then there's the other artifact, which is if you run the machine long enough and change that threshold far, if you change the threshold to the point where you basically meet it every time with a patient, then the detection of the virus itself is no longer useful in terms of determining whether or not there was a certain amount of virus there, and that causes confusion, can cause overdiagnosis. And of course, the CDC is guilty, in my view, guilty of misleading everyone, including the medical community, on what it means to have a COVID-19 diagnosis. They've substituted the presence of a virus or the alleged presence of a virus through PCR, right? The inference that there's a virus there with a medical condition, and that's not what it is. I just did a massive interview with Larry Pilevsky on this on Unbreaking Science. That's my podcast. If you look at hashtag Unbreaking Science or go to WWDMYK Studios on Facebook, we went over this in great detail earlier today. The problem is there's no other condition where there's infectious disease where they say you have the disease simply because you had the virus.
Right.
Because people are walking around immune to all kinds of things, but they have the virus. It doesn't mean you have the disease. And COVID-19 is the disease, SARS-CoV-2 being the virus. They have substituted infection for diagnosis, and that's why their cases are so high. They're getting everyone who even just 2 seconds ago inhaled viral particles, but they don't have an infection. They're going to fight it off. They're never going to ever transmit, but they just 2 seconds ago inhaled it from the person standing in line to get tested just before them. So, this kind of thing. It's
so they're testing for SARS-CoV-2, not for COVID-19.
Absolutely. Absolutely. If anything, you should wait till, the optimal time to test is 3 to 4 days into the infection, but we don't know 3 to 4 days into it. So you should go with symptomatic people, test is symptomatic for the diagnosis. The problem is we're getting this massive, massive uptick in testing. When President Trump came out and said the reason why you're getting more cases is because you have more testing, everybody thought he was crazy. Like, oh, that's that crazy idea that you're just getting more because you're testing more. It's a mathematical truth that you're going to get more cases when you test more. Even if the test is 100% accurate, you're going to get an increase. But this test is nowhere near 100% accurate. I have
what I wanted to ask you about that, the false positives, false negatives. I've heard numbers of 30% false positive or 30% false negative, or maybe it's somewhere higher or lower than that. Do you have an idea what the false negative, false positive rates are?
There's 2 or 3 levels of which we have to say false positive, false negatives. And I appreciate there's going to be some people here who don't know what false positive is. So let's back up a little bit. The sensitivity of a test is the ability of the test to detect the virus when it's present. That goes from, say, 0 to 1 or from 0 to 100%. The specificity of the test is the ability to avoid saying that the virus is present when it's not. Okay. So a false positive is a call for a test that says, hey, you have the measles, but you really don't. You have the mumps, but you really don't. You have coronavirus, but you really don't. So those are all false positives. And you could get a false positive with any diagnostic. There's always a trade-off, if you have a perfect test, there's a trade-off between sensitivity and specificity. Specificity is 1 minus the probability of a false positive. So what we want is test. The optimal test is a specificity of 1 and a sensitivity of 1. False positive 0, false negative 0. That's what that means. You just have no false negatives, no false positives. So, the first place to look at it is, let's look at it historically. The CDC said, oh my God, look, it's coronavirus. Let's get out. Okay. So then the FDA said, we're going to have some testing. Because the CDC screwed up their test so bad. They sent out a flawed test. I did a big show on it. I wrote an article on it. Look up CDC's deadly testing fiasco. They actually shipped out flawed tests, and they didn't say a thing about false positives. They said, oh, it's too sensitive. We have contamination. Now they kept changing their story. And so we have no reason to have any confidence that the CDC has been forthright about why their test was flawed, but nevertheless,
we have no reason to be confident in the CDC, period, but that's fine. That's another story.
I would agree with that. It should be dismantled 100%.
Mm-hmm.
But the Fauci came out, I think it was late February, maybe, saying, yeah, there's a problem with the test. We really don't know why, but there's no bad actors. Nobody did anything intentionally. These things kind of happen. Nothing to see here, folks. Um, but we're going to have to turn to, the commercial sector. So the commercial sector was given the nod to go ahead and apply for emergency use authorization. Well, the FDA gave emergency use authorization to a CDC's test, which was flawed. That tells you how rigorous the emergency use authorization process is over testing. They rubber stamped it. And the problem is that they only paid attention to sensitivity. The EUA, as people know, and it's the one good thing about coronavirus is people are taking a really good look at at how this is done. The EUA procedure only requires that a drug or a vaccine or a test or whatever you're asking the FDA to allow EUA on might work. So what the FDA did was they only paid attention to might detect. They didn't pay attention to might not detect when it never should, right? When it
Oh,
shouldn't. So they didn't demand any data on specificity or false positives. They only demanded data in the EUA submission on sensitivity. Well, I was already in contact with FDA because I took the primers, those primers we were talking about earlier, from the CDC, and I said, "Hey, you guys, you've got a primer here that matches human sequence precisely." And the World Health Organization published this. You guys grabbed it, you brought it over. It's being used. What the hell's going on? And they wrote back and they said, "Thank you very much." This is the head of the diagnostics approval section. He said, "I'll take it up with my team." This is Timothy Stenzel. So Dr. Timothy Stenzel said, "I'll take it up with the team." I never heard back from him. But then I realized, looking at the EUAs, I started the applications from the commercial test providers. I realized there's no real data on specificity. They didn't actually take like 100 sputum samples of healthy people that didn't have any respiratory viruses at all, or they didn't even take water and say what, or a papaya or a goat or whatever. They simply said, here's what we think is going to be a very specific set of primers. And the way that they thought that it was going to be specific was because in the process of selecting those primers, those 21 base pair or 18 base pair sequences, they tried to match those sequences against the human genome and they couldn't find any matches. So that's no empirical guarantee you're not going to get a match in some part of the population. And so, we're looking at a nightmare scenario where you might have a lot of false positives. To get to your question, how many? So what they have to do is they have to do what the Germans did, where they took in sputum. They took 100 sputum samples of people that didn't have coronavirus. You can use frozen. It's fine. It's still, going to be fine. And they said, okay, what's the false positive rate? Just will this falsely amplify anything out of there? They had 100% specificity. The Germans also had a viable test. January 16th, the Germans had a viable PCR test for the presence of the virus, where it was 100% sensitive in the lab, on the bench, not in the field. So then you have this false positive in the lab and the bench compared to the false positive in the field. And the sensitivity and specificity. So sensitivity, they seem to be finding it everywhere they look. Doesn't matter what they test, they're coming up with it. Sensitivity, we're not worried about it. You're going to get it, right? You're going to have a positive pretty much. But the specificity is an issue. And so the fact that they didn't demand any data on specificity, I wrote to Timothy Stenzel at the FDA and I said, you guys need to do this, and didn't hear back from them. They didn't say
hmm.
thank you anymore. And so the empirical estimates, I have a peer-reviewed paper that focuses on the cost of the false positive. It's just been accepted. I don't know when it's going to come out. It's a new journal, but basically the reality is, I cite a paper in there that found 11% false positive from mainstream, like, I don't know, people that I think it was New England Journal of Medicine or some damn thing like that. That it was like, this is non-trivial. Well, in
Hmm.
my analysis, Brian, if you assume 1% false positive and you have a prevalence like coronavirus of 3.5% or 2%, almost every test you do is going to be a false positive if you do a screen. If you screen the whole population, if you test 100,000 people, if you just indiscriminately test people because they want to be tested, almost every test result you're going to get with just 1% false positive. And this lady published this empirical data of 11%. Well, I found that one after I interviewed Dr. Singhang Lee on Unbreaking Science, and he stunned me because I had peer reviewed his paper. I knew that there was a problem. He was citing 20% false negatives and 30% false positives. But what I didn't realize, and what he made clear in the show, was he didn't just take a bunch of samples of people and say, okay, I know the truth because I'm Dr. Singhang Lee. He was given reference sample sets. He said to the FDA, he goes, listen, I am a laboratory. I'm going to create a coronavirus validation process of a diagnostic that uses PCR, yes, but I'm going to sequence the amplicon, the product of after you do all the amplification, you get a body of nucleotide product that's called the amplicon. He actually is going to determine the nucleotide sequence. None of these commercial assays do that. So if you're amplifying, something from human, if you're amplifying something from God knows what, you won't know it. You just have the amplicon, and if it matches in size to the SARS-CoV-2, you're screwed. You've got a false positive. So they sent him, I think it was 10 and 10. It wasn't a lot, but it was 10 samples that were positive, labeled positive for coronavirus out of New York City, clinical samples, and 10 that were labeled negative out of New York City using whatever gold standard that was used to diagnose these patients. And Dr. Lee was able to successfully amplify and sequence SARS-CoV-2 nucleotide sequences out of the ones that were marked negative, that these patients did not have it. Now, you can say, well, he had laboratory contamination. This is a problem. He's a sloppy scientist. Because one of the sequences that he found was a rare variant that was new at the time in New York City, and the samples came from patients in New York City. So he didn't have that variant in his lab. So we have a problem. That was 30% false positive for reference sets that are used to validate molecular tests. Reference sets, mind you. And then he also found 20%, four out of 10 that were supposed to have it. He could not successfully amplify and sequence coronavirus out of it. Now that number, 40%, up to.
Did we lose you, Dr. Jack? Okay.
50%.
I think we lost you just for like 5 or 10 seconds. Can you just back up a few words?
Yeah, no problem. Let me turn.
You just froze for a few seconds.
Sure. I'm hardwired here. I don't know why that would happen. But
I am too.
anyway, so what I'm saying is
because they don't want you talking about this. That's why.
Yeah. So the censor monsters are after me again. So the reality is that he had 20% false negative where he couldn't amplify, and he should have been able to amplify using reference sample sets. If the reference sample sets that they're shipping around for other labs to validate their results are screwed up, then it's just hot mess piled on hot mess, and it's the Wild West, and anything goes. So it seems to me that there's another possible explanation for that, and that the people that were sending him the reference sample set did not want him to succeed. It seems like there may have been some spite, some fraud that way, isolated fraud. But then comes this massive study of, what was it, 3,600 or something? I tweeted it today. PCR results where they tracked down the PCR results. They tried in the samples. They tried to culture the virus out of these people after they either successfully amplified or didn't successfully amplify, no sequencing. And what they found was that even though the PCR test gave a positive result on thousands of samples, almost 40, I think it was 48.7% of them could not be cultured. So that's another kind of false positive where, yeah, the virus fragment might be there, but it's not viable. So we're looking at the CDC using the presence of the virus by a flawed technique as a case for medical diagnosis. Something's terribly, terribly wrong. And this is everything. If we can convince enough people, including senators, congressmen, medical doctors, whoever, bus drivers, that the test is that flawed, and it is, then the whole house of cards comes tumbling down. Everything depends on them saying, "Oh, it's an epidemic, it's a pandemic." There's this huge number of cases. Now, there's an article I want everybody to find. I just also interviewed Jeremy R. Hammond. Jeremy
Yes, I
Hammond.
saw that today. You shared that today, as a matter of fact.
Yeah, go to jeremyrhammond.com. It's out today. Facebook fact check lies about PCR tests and COVID-19 cases.
That was
He
a
has
good
done
article. Yeah.
amazingly documented verbatim.
Yeah.
I mean, this is an affidavit, really. This is just incredible. He's so talented. So check out jeremyrhammond.com and go read all that. That's all your source
Great
material.
summary too, because well, it not only talks about censorship, which is we were just mentioning, but it's a great summary of PCR testing, which it was a good sort of prep material for me with this interview tonight, because I was looking at what the latest thing you had posted, and that was the latest, that was today. So I said, well, let me read this tonight before I have the interview. So that was, thank you for that. Thank you for sharing that. But you know, and even without everything that you said about the tests and why it's flawed, and even if we didn't reveal that aspect of it, what the test actually is, and even if we didn't get into it on the molecular level or any of the stuff you talked about, just the fact that we're not testing for acuity is a fundamental flaw here. The fact that so many of these people that are testing positive are asymptomatic, are perfectly healthy people. So you have people, I know people in the medical profession. I know a lot of people in the medical profession, actually. And, they're seeing these people coming in and perfectly healthy patients, not coming in because they have symptoms of COVID. They might be going into the labor and delivery unit to have a baby. They might be going in to have some other completely unrelated procedure, a knee surgery or something, but they test every single person now for COVID. So you're testing a perfectly healthy person. They're coming up positive. Our cases went up. We're testing all these people. Look at all these people who are hospitalized with COVID. Well, they're not hospitalized with COVID. They're hospitalized or maybe entering the hospital for a completely unrelated reason. And you test them, and they happen to test positive for having SARS-CoV-2, not COVID-19.
That's right.
Okay. And thank you for making that distinction clear. Okay. But that will be reported as a dramatic rise in cases, only because now we're testing everyone and we're not reporting the correlative data, which is acuity.
Yeah. Well, yeah, we absolutely, you're exactly right. And so the way I look at this is, first of all, everybody in diagnostics and medicine knows if the prevalence is low, like cancer, the prevalence is low. It's not 13%, 15%, 20%, right? At any given time, at any given age, the actual frank cancer, the prevalence is low. Everyone in biological diagnostics knows that if you screen a population when the prevalence is low without a perfect test, that is specificity of 100%, by far, most of the results that you get that come back positive will be false positive. That's why we don't have a CT scan every year for cancer. If we did, and people say, "Oh, look, I got a lump here, I got a bump there. Okay, go here, go." The next thing the doctor is going to do is they're going to literally stab you for a biopsy. Guess what comes along with stabbing for biopsy? Hospital-acquired infections. Guess what the number one cause of death is? Number 3 cause of death is in the United States. It's hospital-acquired infections. They call them medical errors, okay? So the hospitals are not clean places, all right? So you end up
After
going,
heart disease and cancer? Or
I
yeah.
don't even know. I don't even know what the first two are, but the point is there's such a risk of there's such a cost. Let's call it a cost. There's such a cost associated with biopsies that we all can't be screened for cancer with CT scans every year because the false positive would be through the roof, and we'd all be what is it called? Pin cushions.
Yeah.
And a huge percentage, more people would die from infections than would ever die from cancer.
But they do die from infections. As you said, it's the third leading cause of death. And I believe that to be true. And guess what? What you're saying is opening a Pandora's box. What you're talking about tonight is because this applies to other diseases, other infections.
Yeah, but we don't do it.
Okay.
There is over testing. Don't get me wrong. There's definitely
no.
over testing.
But what I'm saying is things may be reported as a cancer death when it was an infection that was developed as a result of a cancer treatment or surgery.
Yeah, that happens. There's no doubt about it. I mean, I worked in the cancer center at the University of Pittsburgh Cancer Institute. I had a surgical oncologist look me straight in the eye and say, "You know, we kill people all the time. We kill people all the time. They just die because we did it wrong. The surgery, we kill people all the time with chemo. People know this. This is not a mystery. The fact is, there's risks. So, if you're going to be an adult about this, if America is going to adult about COVID-19, we're going to take an approach called balance of risks. And you know about this because
Mhm.
you know about the Fed, right? The Fed takes the following approach to the economy. You got too much inflation, right? Or
Yep.
right, you're going to change the interest rate.
Mhm.
So it's a balance between what is it, the inflation and the uh, recession. So there's a risk of recession and a risk of inflation. Both are not good. So you tweak it's on a balance like this. And the way you have to look at balance of
Seesaw.
risk, it's a seesaw. Both options are bad. You're trying to minimize the harm
Mhm.
overall. So you have to know the cost of recession. You have to know the cost of inflation. What is the cost of a false positive in today's society? The cost of the false positives are the $16 trillion that we've hemorrhaged from our economy. If most
Lockdowns.
results are false positives and people are screaming, oh my God, look at this massive number of cases, whereas deaths are zero, the cost of the false positives are the 450,000 unemployment applications every week. That's all due to the false positives. That's all due to the false positives. So this paper that I have, the
Losing their businesses, small businesses being
half of the
driven out of.
restaurants are closed permanently. Yeah, the shift from small business to big business, making us okay. So this ties it all together in terms of a mature adult approach to this would be balance of risk. Now, I'm going to be
Mhm.
a little bit immature to drive the point home. I once had a neighbor that asked me to get his mail for him, and I had to cross his yard to get his mail. And he had brambles in his front yard, and he had a dog, and the dog crapped all over the place. So I'm either going to get cut or I'm going to step in dog shit, one of the two. I'm trying to map a chart through that bramble patch, right? Where I get as few cuts as possible and step in as little dog crap as possible. That's what we're talking about. The balance of risk approach here.
I'm going to remember that one. Can I use that story as long as I credit it to you?
Now you absolutely should talk about balance of risk, and everyone needs to talk about balance of risk. So the balance of risk approach that I'm talking about is actually a very mathematical thing. When the cost of the false positives is lower than the cost of the false negatives, you should always do more testing. It's just like increase the interest rate, decrease the interest rate. When the
Hmm.
cost of the false positives is about equal to the cost of false negatives, it's debatable. You might test, you might not. But when the cost of the false positive is more than the cost of the false negatives, you better not do more testing. More testing will put you on the slippery slope to destruction. What are we hearing? We're hearing test everybody, more and more testing, test everybody. And this is a very naive approach. This is a naive, uninformed approach towards molecular diagnostics in the COVID-19 setting. Is more testing is always better. That is naive, and that's not going to be helpful. That's actually going to be very hurtful. So this paper, when it comes out, it has to go to the economists. It has to go to the people in molecular diagnosis who know better, the people in radiology who know better. You don't always do a scan.
Right.
You have a false positive risk. You don't always do a DRE for prostate cancer. Guys our age, we should not get it every 6 months. Guys that are younger, 40 or 30 or so, I don't know how old you are, but the 35-year-olds should not be getting DREs for prostate cancer. Why? Because if they feel a lump, they're going to do a biopsy and you could die from an infection. It's not, it's not enough. The risk is non-zero. Not getting a DRE for prostate cancer means you're not going to get an infection from the biopsy that you're going to get.
And you know how many benign lumps we have? I mean, people develop growths all the time that are, most of them are benign. Okay. We talk about skin. Most people see it on their skin. You go to a dermatologist, you get something with it. Most of the time it comes back nothing. All right. And there's always a risk for infection. I agree with you.
Dude,
So
Brian, we always
yeah,
get cancer all the time. We beat cancer all the time. Our immune system
bodies beat it. Yep.
fight it.
Hmm.
Yeah, we don't even know we have it.
Yep. No, I agree with that. I believe that. I'd rather not know. just let it beat it, and I don't need to know about it. Do its thing, you know. But same with this virus, right? A lot of us have had it. Okay, whether we've been tested positive or tested negative, a lot of us have had it, and we fought it off. The vast majority have fought it off who have had it. I do want to get to questions though, because I kind of budgeted an hour for this, if that's all right.
Yep, I'm
Um,
ready.
Okay, and so I want to get to some questions. Before I get to the questions of the general public, my friend and business partner, Dawn, you know very well, she could not be with us tonight, but she did have a few questions that I want to pass along. So one of them was, do you think it's still a good idea to be testing? I mean, now she didn't hear this interview, okay? So maybe she would already know the answer to the question, but do you think it's still a good idea to be doing the PCR testing? And if so, why? Um, just sort of in a
Um,
general sense.
PCR alone, no. I think every PCR test should be validated with Sanger sequencing. I'm 100% convinced that we need to not do PCR alone testing. We absolutely, the patient has a right to know what was amplified in their test. Well beyond the number of threshold cycles, whatever amplicon you got, I want to know what it was. Okay. And if it matched SARS-CoV-2, great. Now tell me, did you quantify that enough to let me know that I was actually infectious? Because if I don't have enough inside, I'm probably not. I'm asymptomatic. I'm probably not going to be infectious. I'm no longer going to feel very good about my 14-day quarantine, trying to protect
Hmm.
other people if I know that I'm not infectious.
Hmm.
Okay, so they have to do quantitation and they have to then also do tests if they're going to use PCR.
So you're not against testing in
No,
general?
no.
Okay.
No. If you're sick and you should definitely do a differential diagnosis. If you have COVID-19 like symptoms, you should definitely figure out if it's this virus or not. While you're taking the blood draw, whatever you're doing when you're admitting the patient, you should absolutely also look at their Th2 and Th1 counts. If the patient comes in and is Th2 skewed and has COVID virus and has glassy opacities in their radiography. See, you don't just look at the PCR test. If they look like they have COVID-19 symptomatically and they test positive and their Th2 skew, that patient's going to die on you. You need to know that. Now, we could talk later about why patients in the population are Th2 skewed. It starts with A, ends with M, and rhymes with aluminum.
Well, let me let me ask you this though. I mean, if someone's symptomatic though, even if they are symptomatic, why do they need to be tested if they're going to stay home anyway? If they're sick and they're going to take a precaution, I'm going to stay home for 14 days, which pretty much most people do nowadays. They get a little sniffle and then they're going to quarantine for 14 days. If you're going to quarantine for 14 days, why the hell do you need to be tested?
I guess I'll just answer it quickly. There's an icy slope on this side of the house or the roof, and there's where the other side where it's all melted and you can walk around and you're safe. Just going a little bit towards not testing and just go asymptomatic, they're still going to give everybody that's asymptomatic the diagnosis. We need to rule out COVID-19. The test sometimes rules out COVID-19. Gosh, I thought for sure that this patient had COVID-19, but I tested them, they didn't have the virus. The problem is, instead of using the test legitimately, if you test negative for COVID-19 and you have symptoms, what are they going to do? They're going to test you again. And they're going to test you again.
And they still treat you like
and
you
they're
have
going
it
to test
anyway.
you again until they get a positive. It's sick. Furthermore, Brian, if you go in and you say, look, I want to get tested. I got to get tested. I was in contact, whatever. My family wants me to get tested. And you test positive, you had COVID-19, and it gets reported to the government you had COVID-19. If it was a false positive and you test negative the next day, that number's not retracted. They don't rescind their counts. So
Right.
if you
So that's
test
why I
three
think a lot
times
of
in a
people are
row,
hesitant to get tested, though, because they don't want to be in that database if they didn't really have it.
the reason why people are hesitant to get tested is because there's no rational basis for testing, right? We all assume going to the doctor, oh, I'm going to get this little swab for what was it, for some kind of respiratory thing, staph infection. I think you probably have staph, got a sore throat, staph, whatever. We're going to test you for staph. Okay, there's a rational basis for that, right? It doesn't lead to societal shutdown. It doesn't have the cost of each false positive is the equivalent to losing a job in the United States. That's why we have to be very judicious about how we caught. In terms of trillions of dollars, we can actually calculate if if half of the cases are false positives, and then we can actually calculate per trillion per using the trillions of dollars, $16 trillion lost, uh, exactly what the numeric financial cost of false positives. Not to mention the people that die because the deaths of despair and all the other stuff we haven't talked about. The mass, the healthcare, the mental health community cannot keep up with teens that are threatening suicide right now. They can't do it. So this lockdown is not just like, yeah, we need to lock down for the greater good. Let's define the greater good as getting through the bramble patch with the least amount of dog shit on our shoes as possible.
Well, and I agree with that, but again, I would, me, I'm not going to shy away from pushing back a little bit. I still don't see why we want to do any testing at all. If the cost of false positives is so high to mental health, to the fiscal health of this country, I mean, I think every proud American and patriot should be avoiding testing like the plague.
Well, not everyone. If your 80-year-old grandmother goes in, right, she's got severe pneumonia. She gets a radiography exam and it comes back with glassy opacities. That's unique. That's a unique
Okay.
characteristic.
All right.
Right?
That's a fair point. But the general population, I'm not talking about the
I
highest
agree.
risk.
You should not be, if you're healthy and walking around and you don't have any symptoms, you should not be tested. I don't care if you were in contact with somebody else that had COVID either, because having having a case of COVID is the same thing as having no symptoms and a false positive test, or worse than that, having no symptoms and having been in contact with somebody who had no symptoms, who was in contact. It's ridiculous. So I agree. If you're healthy, you should not be tested. This is
But
not
if you
medical
have any
advice.
symptoms at all, you still should be, even if it's just a
No,
little sniffle.
no, 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 no. See,
Okay.
women get lumps in their breast all the time. The analogy works much better because COVID shuts off part of our brain. We were programmed to shut down our rational thinking over COVID. Here's the thing: women get lumps in their breast all the time. An ethical physician will tell the first thing they'll tell a woman who's got lumps in her breast is stop drinking coffee, see if they go away. And if you want to know, I'll tell you that it's because they're fibroid cysts and coffee, reduce your caffeine, they go away.
Mm-hmm.
They won't biopsy her. So no, not everybody that walks into a hospital with symptoms should be automatically tested with COVID. What they should be tested for is glassy opacities first. If they have glassy opacities, then they should be tested. That's just the scientific literature. And I have to say it again because I'm not sure I got my point out. This is not medical advice. We're talking about how to save society, save the United States of America.
No, I know. And you always preface it, you're not a medical doctor, you're a scientist, and you're not, that's not why you're here.
But I said it quite bluntly, and I could get in trouble. I said, if you're healthy walking around, you should not be tested. I think I should say that more carefully. From a public health perspective, a good public health measure that needs to be adopted is to not test healthy people.
Right. But regardless, putting aside the legal pitfalls of what you might be worried about, I don't think there's anything wrong with what you said, and I'll tell you why. Because you've always made it very clear you're not a medical doctor, you're not giving medical advice. You're allowed to have your own opinion. All right. You're a human being. You're an American. You still have the First Amendment for now. Okay. You're allowed to have your own opinion. She has another question, and then I'm going to get to the public questions. Two quick questions, actually. How do we avoid it being mandatory in the workplace, if you can answer that? And how do we teach others that PCR equals garbage? So those are the last two questions.
Well, I would share this video and Jeremy Hammond's article of today. That's how you teach others. Then I would write to your congressman and senator and say that you need your HIPAA rights back. There's no reason in this world that workplaces need to know your medical condition over COVID-19. It's ridiculous. They relaxed the requirements on HIPAA. Now that they've made it so you cannot sue your employer for anything related to COVID. Okay, that they're indemnified. The only people that could sue a place is you go to get your haircut, you pick up COVID there. Why didn't you screen your people? You didn't screen your people. There's liability, blah, blah, blah. No, wait a minute. We have to have the rights of all the people protected. And so the workers, they need to be protected too. Your medical information should be private. If you have COVID, if you don't have COVID, what we need is to say we need a mandatory 2-week vacation twice a year. Doesn't that sound much better than destroying our society? And you don't have to tell your boss why you took your 2 week vacation. You don't even have to mention it. You just say, I'm using my 2 week vacation. See ya in 2 weeks.
Right. And you know what? I mean, it's not only about medical privacy, although that's a big one. It's about bodily autonomy and privacy because forcing someone to get this test. Listen, these up the nose tests are no joke. My wife has a friend who is a healthcare worker and had to get this as a requirement, had to get this test, the up the nose, test for, because now, you can do them in the cheek too, but still a lot of them do up the nose. It ruptured an artery. Okay. She had to have emergency surgery. So the question became was, well, is this covered under workers' comp? I mean, they forced me, and luckily she's okay now. She had to go to an ear, nose, and throat surgeon and get this repaired. It was emergency surgery. She was bleeding uncontrollably. She lost I don't know how many pints of blood. It was a lot. It could have been really, really dangerous just to get a test. Now that's an anomaly. I don't hear that happening every day. But nevertheless, there are risks. Anytime you do anything that's invasive, you're putting something in an orifice, someone can screw something up. There's always a chance. They talk about some tests maybe being contaminated. I mean, who knows? You know, I don't really know about any of that. All I know is that I should have the choice. We talk about this with vaccines all the time, right? I should have the choice to decide what goes into my body. Same with mandatory flu shots, because guess what's coming next? It's not just going to be mandatory tests. It's not just going to be mandatory masks. It's going to be mandatory vaccines. All right.
Yeah.
And we have to push back against that.
Well, you will remember that the very first, my position on testing was in-home private testing.
Yes. I had
And
the interview you did about 6 months ago. Yes.
I got my ass kicked by people. What are you saying? No, we don't want any testing. No, Dr. Jack, stop it. Don't do that.
Well, because you said they were going to mandate it anyway.
Guys, you guys have to have in-home private testing.
Right. I remember that.
If you want to know, don't blow up your life if you happen to test positive. Get a full official clinical diagnosis. Again, the analogy that I pulled out, I think it was a month. I spent a month on this on social media, was pregnant women women who think they're pregnant, they're not pregnant until the doctor confirms that they're pregnant. I mean, they're going to have their baby if they're pregnant, but if you pee on a stick and you get an EPT and you pee on a stick, no doctor in the world will do anything medical to you until they run their own independent test to confirm that you're pregnant. So what did I imagine? What I envisioned was people screening themselves. Now you have your body of true positives and false positives. You got your false negatives out there too, but they're rare. You got this group of false positives and false negatives. Now it should be the medical community's job to sort that out. Hey, doc, I think I tested positive. What should I do? Stay home for 5 days and see if you develop symptoms. That's what a good doctor would say. Not rush into my office where I've got a bunch of coronavirus and I've got other respiratory viruses. Stay home for 5 days, see if you got symptoms. If you develop symptoms and you think that they're serious, don't come to my office. I'm going to send somebody to you. That's what I envisioned. We were all scared crap, had the crap scared out of us about things. We're going to send someone to you. We're going to confirm your diagnosis with a valid test. And I had always thought for sure that they would be sequencing things, but let's get to the other questions.
Yeah. No, we've got a few of them here. Sherry's asking, so the more cycles you do, the more chances of you being positive. Is it looking for the COVID-19 virus? I guess is SARS-CoV-2 she's asking about. You talked about this already, I think, about the cycles. So maybe she missed it, but if you just want to quickly address that.
Well, what I want to say is that there's a bit of an oversimplification of that understanding. Remember that the threshold is the number of copies. The fluorescence measures the number of copies. So this way on the graph, that's going to be either high or low, depending on two things: the amount of original starting material and, yes, how far you ran it out, but really where the threshold is. So any public health official that's citing number of cases that are based on PCR tests that does not publish which test was used and the threshold number of cycles, not the total number of cycles used. For every patient, you could do a full 40 cycles. It's fine. It's where you look at the data. Okay. If you look at the data at 19 cycles or 20 cycles or whatever, that's what we're talking about. And the person has to be above a certain amount of fluorescence to make it a positive. The public has a right to know what test, the accuracy of the test, sensitivity and specificity, and it has a right to know what threshold was used. If you're not publishing your threshold, that's all FOIAble, by the way. You can ask; they have to answer. But if they're not publishing it, they should be arrested. That's my opinion. That's the opinion of ethical skeptic as well. They're hiding information.
And Sherry gives us an update. I'm very sorry to hear that she lost her job because she refused to do it weekly. So there are people. You're talking about the economic cost. There are people that are losing.
Sherry, let me give you some advice. Whatever you were doing, go create the competing company, because the company that you just met, that you just fired you, they're going to go down in the tubes. They're going to be firing people after person, because America's not going to set up for the bullshit. Go create the same exact kind of company, become the CEO, and do it yourself.
Yeah, I mean, it's if she was a healthcare worker, I don't know how she does that, but yeah, but
Did you know
hopefully,
you don't have to have an MD to own a medical facility?
well, you can own a facility. That's
That's
true,
right.
but
You can
not
own a
practice.
facility.
Yeah.
Sure. Just
Yeah,
hire
I
good
don't know what she
doctors.
does. I don't know what she does. Listen, they're doing weekly COVID. I heard somebody who works at some I don't know, some kind of auto sales or auction place or whatever. They were making them getting tested. I don't know if it was every week, but every month or something. I mean, they're going to start doing this everywhere. You could be working in a florist shop. You could be working in a dental office.
Call
You
your
could be
congressman.
working in a bank, and they're
Change
going to
the
make you
rules.
get tested like
Change
on
the
a
rules
monthly
in
or
your
weekly
state.
basis.
Call the congressman. Send this video to your congressman and your senators. Change the rules in your state.
Absolutely, absolutely. Let's see. Let's see. Someone else is asking another question. Oh, how about this one from Stefan? Is it true that the PCR isn't designed to test for infectious diseases? Well, you talked about that. It's true that is it again? Some of these people are just jumping on the last 15 minutes,
Yeah.
maybe 10 minutes. Is it true that COVID-19 hasn't been isolated or purified? So, what are tests been calibrated to if they don't have that gold standard to go by?
Yeah, this is the virus has never been. And you recall, I was part of a debate that you set up with a bunch of people who I hate to call them a bunch of people, but they're doctors and and citizens alike. Everywhere I go, I run into the question, why even bother testing? Because the virus doesn't exist. And I'm sorry, the virus does exist. There's something like 190,000 copies of the viral genome in the public databases. It's been isolated. They've isolated it. They've taken pictures of it. They've taken pictures of the proteins. They've done X-ray crystallography on the proteins. Let's see what else. They purified it to the point where every time you enculture a virus and you see viral growth in the tissue, right? You know what you've got. So how do you know what you've got? PCR, down the rabbit hole you go. Whatever. The point is, yeah, the virus exists. I found that the SARS-CoV-2 spike protein probably existed as far back as 2005 in a sequence called the HKU33 sequence from Hong Kong, and Ralph Barrick's lab downloaded it in 2008. None of these scientists knew that it was COV2 like spike protein. And I keep saying, and I published my report, and nobody seems to be cluing into the fact that when you talk about the furin like cleavage and all this, you've got to go back to that sequence to see if it's there in 2005. So SARS and SARS-CoV-2 are sister viruses. They are isolatable from the wild. In my view, yeah, I think somebody caught it from Wuhan, from a lab animal that scratched them, and that graduate student went missing. It's the missing graduate student, or the missing lab tech. I forget her name, but not the missing virus that I'm concerned about. PCR can be used to test for infectious diseases if it is used appropriately. It is a tool, just like you can't use an X-ray to diagnose a broken bone under certain circumstances. You have to be very careful how you do this. Mammography won't pick up all breast cancers.
Right.
We just did a whole show. The rest of the discussion answers all that.
Right. Thank you. A nurse said she was instructed to place all the PCR samples in one vial. Wouldn't that contaminate the samples? I don't know. I don't know how often that happens, but
it happens if the laboratory actually is doing what's called pooled samples to try to increase the throughput. They have so many samples to test. They'll put the samples from 5 patients into one test tube. And then if that test tube comes back positive, Then they will do confirmatory reactions on independent samples. But any test tube that comes back negative, they just screen those people. All 5 are clear at one time. They think it's a cost savings. Not all 5 people get notified. Hey, your test tube that when we put you in and 5 other people came back positive. You're all
Right, but if you
positive.
have to go back and retest, is that a cost savings?
It turns out it's one of these balance
Again,
equations.
overall,
It depends on the
maybe.
prevalence. If the prevalence is everywhere, no, it's
Right.
not a cost savings, right? If the prevalence is really, really low and most people are going to be negative, truly negative, yeah. But in the case where most of your results are false positive, you're doing a lot of extra testing runs you don't have to do. That's for sure.
All right, here we go again, questioning virus sequences. So here you're the person to answer this. Listen, hey, we allow all perspectives. We have
Absolutely.
all
I'm
voices
laughing
here.
because it just won't go away. I don't
Well, no,
mind.
that's kind of why I'm laughing too,
I
because
don't
the
mind
question,
answering.
because every single time you come on, there's
Yeah,
questions about this. That's kind of why I'm laughing too, Jenny. I'm not laughing at you because
not at
there's a
all.
lot of
It's a
people
valid
that I respect.
question.
A lot of people that I respect very much that have varying views on virus and germ theory and all kinds of things. So
Yes.
you want to respond to this?
I do. So here's the deal. If remember when we thought that exosomes, that the virus was exosomes, because that biochemist said, look, they look like exosomes. And you hear people say that this virus actually resided within the human genome originally, and then 5G brought it out. If that was true, then when I download a bunch of sequences of SARS-CoV-2, right, it should show genetic history of the human race. I should be able to, if these sequences came from the Chinese, these came from Japanese, these came from somebody in Nairobi, these came from the Irish, I would be able to reconstruct the evolutionary tree of humans using the SARS-CoV-2 genome. That's not what we see. What we see is it went from a Scotsman to a China lady. Then it went to Germany. We see it being the transmission, the phylogenetic history that's encaptured by these sequences matches the transmission chain that is known in contact tracing. I don't know how to say it any clearer than that. Those are technical terms. But Jenny, it's a great question to say all of these are just computer models or synthetic analogs. Part of that may be motivated by the fact that when you do sequencing, you have to then assemble the reads in a computer. To that extent, it's true. But that doesn't explain why we don't get the evolutionary tree of human beings from this other question. But we see a high fidelity transmission chain reconstruction when we do it, and I can't stress it enough. The virus is real. Some people do die from COVID-19. The glassy opacities in the radiographic journals that were early, they're still seen today in people that have pneumonia with SARS-CoV-2. That is, you have infection out to the periphery of the pleura in the lungs, of the alveoli in the lungs. That's very unusual for a respiratory virus. So it's real.
Right. And this is just sort of a comment she has that a low number of positives identified with different COVID tests. And Liverpool has demonstrated how the PCR test inflates the numbers. You know, I don't know if you've heard about that, but she's done some research apparently, because you know she definitely has some I think some introspective questions here. All right,
So
so
many people do. We have such a smart community.
yeah, we really do. I don't have a lot of other questions. I have a lot of comments, but we're past the 1 hour mark anyway. I don't mind going over a little bit, but if you just want to wrap it up, um, Dr. Jack, if there's anything else that you want, let me just see if I get this off the screen. There we go. If there's anything else you want to say, again, tell us about IPAC again. Tell us about your podcast, which I think everybody should start listening to. That sounds like a fascinating interview you had today with Dr. Larry. So advertise that again, and then we'll send you away.
Sure, no problem. So if you look up Unbreaking Science, the idea here is to talk about what's wrong with science today and how we can fix it. I have another one called Talk Nerdy to Me that's coming. That's nerdy with an N. And that's where I geek out on quantum physics and other things like that, just for my own mental health. That's my happy zone. Um, so listen, the most important thing that I can say right now is you've got my article on false positives coming out. You've got Jeremy Hammond's busting the Facebook fact checker on that. We need to hammer on testing, but not in the echo chamber. The stuff that I produce, the stuff that Chris Shaw produces, the stuff that other scientists produce, this is absolutely key that you take it to your elected representatives. Everybody wants to bring me to their elected representatives. I can't be in all 50 places at once. And I appreciate that. I've tried. You've seen me. I'm all over the place. And I'm sorry I couldn't make your last one, Brian. But the point is, you should communicate to the best of your ability why the studies that we're publishing are important, why the papers and perspectives are important, and not just for the sake of winning an argument at Thanksgiving, right? I think they're saying don't go home to Thanksgiving so that people don't cross pollinate ideas. I actually believe that, right?
Smart. I
I
didn't
actually
think of
do.
that, but you know what? That makes a heck of a lot of sense.
Yeah. Have nice, long, calm conversations. Unless you have a molecular diagnostics expert at your table. And now people must wonder, like, what's it like when you go to Grace's house for Thanksgiving? Everybody just must circle around with amazement at your genius, right? No, I'm just another family guy. I'm just like, yeah, you think so. Don't worry about it.
Well, everybody
Have
just thinks
fun.
I'm crazy, so I don't get any questions. But
Yeah,
um,
people are pretty. But I want you to take these messages to your congressmen and senators, even though you think it's not going to go anywhere. If you don't put it in the minds of the people who are representing you, if you don't make it available to them in your own words and say why this is important to you, that we just absolutely take another look at testing from the ground up. Some of Dr. Singhang Lee's study, you can find it in Bloomberg News, in Yahoo Financial News. It made a huge, right. You can't have this level of false positives and be doing this level of screening and not destroy your society. This is what an apocalypse looks like.
yep.
It's the technocrats are just chewing away at the edges, and now they've got the hold of the artery.
And apocalypse is the word for it because it's being created not by the virus but by the reaction to the virus,
100%.
which I believe is quite manufactured. I mean, personally, I was just actually talking earlier tonight. I was having a conversation earlier tonight, and I was saying that, and this is just again my personal view. I'm not saying putting it out there as I have evidence of strong evidence to support all of this, but I firmly believe that this was manufactured. I don't think it was released by accident, Jack. I think it did come from a laboratory. I agree with you there. But I think it was deliberately released for political reasons because China wanted Trump out of office. Because what can you do once you release this? And they knew the reaction, and I believe they were in collusion with the Democrats, Democratic leadership, that they were going to shut down this country, which would justify mail-in voting, and that would give them an opportunity to commit the massive fraud, which I believe has been created. Again, this is not the position of my organization or anything. This is just me, Brian, speaking. Okay, my personal belief is that this was orchestrated from the very beginning for political reasons, nothing to do with public health, nothing to do with all the other great benefits that they've gotten from it about controlling us and the vaccine. I think those are all pieces to it, but I think the biggest thing, what President Trump was doing to China was what no president has ever done to China. Okay. And holding them accountable, placing tariffs on them, it was going to ruin them. And it was going to place us above them. I shouldn't say going, because I still think there's a chance that, we're going to see something wild happen with this election. But China absolutely wanted him out of office. And this was a way to do it. And it was a brilliant plan. It was diabolical, but it was a brilliant plan. And that's personally what I believe happened. Now, people call me crazy, say I don't have evidence for it, but if things fell into place too perfectly for them, for this not have to be hatched. Oh, it's just such a great coincidence that just in the election year, when, this president that's done things to us, worse than any president, in the history of America is coming after China, finally holding China's feet to the fire. And where does this virus come from? China during the election year. I mean, it's like it's sort of like we say with vaccine injury so much that it's just a coincidence. Oh, it's just a coincidence. And that's one of my favorite memes I ever saw on Facebook was vaccines, the leading cause of coincidences,
Yeah,
because everything seems to be a coincidence, but it's correlation doesn't equal causation, but when you have a strong enough correlation and it happens often enough, then you got to start thinking about causation at least.
Okay, so let me just comment on the significance of what you said, and I'm 100% convinced that you are fully aware of the significance of the allegations that you just levied, which actually are very substantial. That means that Anthony Fauci and people working with him are agents of the Chinese Communist Party.
I believe they're in collusion. That is my personal
No,
belief.
you're
I didn't
also a
say
lawyer.
allegation. I didn't say
No,
allegations.
right,
I
right, right.
believe.
Okay. Well, what I'm saying is, if it were taken as an allegation, but you're going to mince words like nobody else, because I know you and I do the same thing, and that's fine. My point is, there are consequences for acting in the United States as an agent of a foreign government without registering as such. When I say agent, I don't mean secret agent. I mean
I
you're
know what you
acting
mean.
on behalf of the betterment of a foreign government at the expense of your own country. That makes him a traitor. That means that we're sitting on top of, a powder keg.
Hmm.
And
I agree.
of course, this I'm translating what you say. I'm not saying that it's my opinion. I'm
I
saying these
know.
are the consequences. And if you think it through, then the election is a death throes match between a group of people who have infiltrated our government. They were giving viruses to China. They were giving money to China, including the Zika money. All right, working on behalf of keeping this gain of function bullshit research going against the common sense and against the moratorium. Um, with Obama being involved in that as well, he allegedly knew about all of this stuff and was supportive of that money being spent that way. Um, then we're talking about a death throes match between people who think that the United States of America should live and act, breathe in a rather independent way and not walk lockstep with the biggest guy in the block. It's going to be the world dominating political power. And I haven't even been able to drink that whole glass of Kool Aid. That's tough for me because if it's true, I mean, the consequences are stunning. There's going to be a Republican president in the future. And the only way out of this for them then is for pharma to bribe both sides of the aisle as heavily as they've bribed the
But they
left.
do though. But here's the thing. Trump is the first president that wasn't controlled by them the way that all of these other ones. There'll be another Republican president, but if you get another George W. Bush, that's their dream.
Yeah.
That's not their nightmare. That's the dream. Bush wouldn't go after them the way that Trump went after them. Like I said, nobody went after China, and nobody would go, and everyone else is bought and paid for it. Maybe not if it's Donald Trump Jr., okay, or maybe not if it's Trump for a second non-consecutive term. But the vast majority are bought and paid for on both sides of the aisle. I mean, what did Republican presidents ever do to expose the fraud at the CDC, to expose the truth about the vaccine program? What have they ever done?
They
Trump
help
hasn't even done it. Trump
they,
hasn't even done it
they
yet.
they help normalize the fact that it's part of the game and that success in biomedicine means investment. Um, so
Mhm.
let me lay on you my analysis of the political landscape, and this is going to help some people that might be
I'm
struggling.
sorry this is devolved. I was about to let you go, and now we're talking politics.
No, we're not talking. Listen, everybody seems to think that there's a left and a right in the country, and there's not. And you're going to agree with everything I'm about to say, but it's really crystallized for me that the political spectrum itself moves left and right, decade to decade. That social issues, economic, whatever. And then we have the extremists in both parties. We have the extreme right and the extreme left. And when the extremists are in power, it's a very dangerous situation, right? But then we have the people think that there's a pendulum that goes back and forth. It's not a pendulum. The landscape itself is moving. The land underneath the pendulum is moving, but then on top of it, there's not a pendulum. There's two of them. And when the parties go towards moderate, we have a huge middle. And then when the extremists take over, we have not such a huge middle. We have more people going away from the right, but the moderate Republicans or moderate Democrats or the moderate middle. This massive, massive amount of America is most America. Every day of your life, it's most America. People go extreme on certain issues, but every day of your life. So what we need to do is disempower the two extremes. And we need to say people matter. Now, my question to you, Brian, I've asked a lot of people this question. How do we get a single party system in the United States without it being a dictatorship and through democracy? How do we do that?
Well, I'm not going to advocate for a single party system. I don't think it's a good idea, for a lot of reasons. But I wish we could have something other than a two-party system. And I know a
But you
lot of
can't
people.
because it's chaotic. It's the chaotic pendulum. If you have a single pendulum that swings like this, right? It's stable. The two-party system is well known to be the most stable system, other than a one-party. If you add a third party, you have chaos, literal chaos in your political system, and that's why nobody wants to throw their vote away. They don't want
Well,
to.
why does it have to be party politics, though? I mean, this is the way it's
Exactly.
evolved. Why does it have to be about a party at all?
Exactly.
Um, if you're talking about a one, if by what you mean by saying a one party system is really no party, then I would agree with you. Because once you have a party, then you have a lot of corruption. You have a lot of money being funneled places. You have people, these organizations like the RNC and the DNC,
Yep.
which are just well, whatever. I don't want to go on and on and on
That's
about it.
okay. It's okay.
But
You're
I do
exactly
want,
right.
but I do want to say thank you, Dr. Jack, for coming on tonight because I think you've really enlightened a lot of people about PCR testing and a lot of other things. But I think we always need to have these opportunities, like you said about the Thanksgiving table, sitting down at the dinner table and have calm conversations, even though I don't always seem so calm. This is pretty calm for me tonight, actually. But to have these calm, rational, civil conversations with each other and be able to have this kind of civil discourse, I think is so important in this country right now. Whether we're talking about politics, whether we're talking about COVID-19, all of these hot button issues, racism, all these other things that people are talking about. We need to be able to sit down and do it like this. And I like this format. I mean, you mentioned there's one good thing to come out of this COVID situation. I think there's a few good things. Another good thing has been the proliferation of these kind of online events, these seminars, these conferences. I did the 24-hour marathon, which I plan to do every year now. You
Yes.
know, things like that grew out of it, and we can bring everybody together. I mean, we had the ability to do it before, but for some reason, we just prefer, and I still prefer in-person events because I like connecting with people
It's
in
mostly the
person.
alcohol. It really is.
Well, that's the big part, and the food. I like the food too.
Yeah.
But alcohol, yes. But the issue is the expense when you're trying to plan an event and you want to have 20 different speakers.
Yeah.
You know what that would cost to fly them from all over the country when you have people in California and in
I
Texas
do.
and you in Pennsylvania. I mean, it's too much. It's too much. But now I can do something. And again, I could have done it before, but we weren't doing it as much before. So there have been a lot of good things that have come out of this. But again, I want to thank you. I could talk to you all night, and
Yeah,
I know
likewise. I
I
will do that final pitch of IPAC if you don't
yep.
mind, because we
Go
have a
ahead.
really super important study. If you know what I'm talking about, and I'm not going to say which study it is, but it's the one you're thinking of. It's accepted for publication, and there's an open access fee for the journal. So if you're not already an IPAC supporter, go to ipaknowledge.org and pitch in a little bit with all of your other vaccine risk aware Americans, and kick it a little bit so we can make the open access fee. And on top of that, then I when that one hits the press, then I have approval from Dr. Paul to take his data and do 4 more studies on different questions about vaccine uptake. Okay. So go home and to your turkey this Thursday, the next Thursday, call it a funeral, and then you can have as many people as you want. It's a
Right.
funeral for the bird,
I've seen that one floating around Facebook too.
right? But it's your American duty to go home and have a civil conversation, because it's not happening elsewhere. If you can't talk with your family, it's your duty as a good American citizen. Stand up for the red, white, and blue. And let's make this a patriotic task. Talk about testing next Thursday.
All right. Awesome. Thank you so much. Happy Thanksgiving, Jack, and happy Thanksgiving to all of you out there as well.
Happy Thanksgiving. I'm sorry about everybody's bird. I'm really sorry about it.
My condolences.
My
All right. Take care.
condolences
Have a
to
good night.
everybody.